6 years ago. And have just really loved it. And then, of course, moved into this COVID vaccine thing and became our resident expert on COVID vaccination. So that's what earned me the spot here. So I just created a tiny little presentation here for you. I've got so many screens here. It takes me just a minute to get everything where I can see it all. All right, can you see my first screen here? Perfect, awesome. So Missy just kind of asked me to talk about a few different things about the COVID-19 vaccination for 5 to 11-year-old children, about the safety, efficacy, and how to get one. So first of all, kind of the nuts and bolts of the vaccine for children this age. It is a Pfizer product. It's formulated a little bit differently than what 12-year-olds and up get. So it comes in even a little bit different container, but same vaccine, just formulated a little differently so that children ages 5 to 11 get a 10 microgram dose versus the 30 microgram dose that 12 years and up get. It's based on their age, not on their weight. And it's the same as previous Pfizer iteration where you get 2 doses separated by 3 weeks. And for those littler kids, it can be given either in the arm or in the thigh, kind of your preference. And I know a lot of people have questions about if it's okay to get the vaccine at the same time as other vaccines, and it is indeed okay. We've actually given it to lots of kids at the same time as a flu vaccine or even as their routine childhood immunizations. So why might you choose to vaccinate? Lots of different reasons. Of course, lots of people out there, you might hear that, why should I vaccinate? My kid's a lot less likely to get seriously ill from COVID, but it can happen. There are special considerations for pediatric patients that develop COVID. You can see we've seen about 1.8 million COVID cases in that age range, the 5 to 11-year-olds in the United States. And with the Delta variant coming around, we're seeing a lot more kids get sick with the Delta variant. One big bonus to getting vaccinated is if your child is fully vaccinated, if they have an exposure, they can remain in school, which means you can also remain in work and just monitor yourself for symptoms, just like any of us who have been fully vaccinated. So that's kind of a huge perk in my mind. And then also, you're protecting your child, but you're also protecting everyone else around your child. So maybe elderly grandparents or infants who are too young to get the COVID vaccine at this time. Those are some of the perks. So safety, really this age group, researchers followed just 3,000 children for a little over four months. And during that time, they didn't see a lot of side effects. So the side effects that they did see were pretty much the same as what you and I have had: a sore arm, maybe a little bit of a fever after the second dose, or chills, mild headache, fatigue. Everybody, of course, is talking about the myocarditis or pericarditis, and that is something that was not seen in this group. I might let Dr. Maurer talk more about that if people have questions, since that's his field of expertise. But really not a lot seen in these young children as far as side effects go. And then as far as efficacy, the same 3,000 children that were monitored, they saw 17 COVID cases in the placebo group versus just 3 in the vaccinated group. Do the math on that, and it comes out to be 91% effective after 1 week post the second dose. And of course, everybody probably knows that after 2 weeks is when we decide that we're fully immune. Well, as immune as you can get, right? Okay. And then just kind of where to get the vaccine. I think most local pediatricians in Grand Traverse County anyway are carrying the vaccine. Also, quite a few local pharmacies are, local health departments. This vaccines.gov, I will wonder if I should click on it, if you'll actually see it, or if I'll have to go to a different. Can you see that on my screen, or do I need to choose? Perfect. Yay. So if you navigate through here on the vaccines.gov, and I can share this slideshow with Missy to share it out with all of you, then you can just click through and you can select if you're looking for your pediatric dose or an adult dose, which brand you're looking for. Oh, and you have to enter your zip code. Are you still following me on the screens?
Yeah.
Perfect. Awesome. And so then it would show you all the different places that it was available. Now let's see if I can get back to where I was. Am I back on my PowerPoint or no?
No.
No. Okay.
You're on the myocarditis slide.
Am I? Okay. Let's see. Oh, there it is. Are you seeing it? Okay, perfect. So that will show you where, and then, oh, sorry, just at the very last minute, I got super interested in this article from Children's Hospital of Philadelphia. I love this site for information about immunizations of any sort. They really do a great job of explaining, I don't know, just different nuances of vaccination and answering all your questions. So this article, if it'll come up, yeah, just talking all about different considerations about the COVID-19 vaccination for the 5 to 11-year-old age group, including that myocarditis piece. And of course, there's lots of discussion around fertility, which is all not proven at all, but people have anxiety about introducing something new to their children. So that's fair. Anyway, that's what I've got. Let's see if I can figure out how to stop sharing here.
Thank you,
Oh,
Arda.
yeah, you bet.
All right, so I know I've got questions in my head, but we're going to try to hold our questions. We're going to give Dr. Maurer some time. You've got the floor to show us what you've got.
Right. So a little bit of background for myself. I actually grew up in northern Michigan, a little dot called Pellston, and I went to school at Michigan Tech, and then after that left the state for 30 years doing my thing, and then right about the time I retired from the Navy, I retired briefly to a practice in North Carolina. And I see Gwen's on the line here, and I met Gwen at a conference a few years in that period of time, left my name with her, and was recruited later by University of Michigan. Came back to University of Michigan about 5 years ago to a practice in Lansing, then back up north about a year ago. I live up north. I live just south of Charlevoix. But I run offices in Petoskey, Traverse City, and Quarterly in Alpena. But I live and work in northern Michigan. And although I'm connected to U of M, I'm actually in a separate bubble almost. You can see my area of practice from a satellite. I cover everything north of Gaylord and all the way into the eastern UP, and it's pretty much just me. So, but I live and work up here up north, and work for University of Michigan, and that's how I got to be here. So I'm going to throw up. I have to admit, I wasn't sure exactly what you would want in this slide presentation. So I'm going to try to do this talk, and I hope it's not too far in depth or too crazy. I did try to just sort of keep it to clinical stuff that you might need, but we can fill it in more. I could easily fill hours talking about any aspect of this and trying to cram into what I think might or might not be relevant for your group was hard. And so I apologize if I go fast or go through it. I just want to talk about the risks and benefits of the COVID vaccine. It just as a quick comment, I'm a cardiologist and I don't consider myself an expert in coronavirus, COVID-19, MIS-C, or vaccination. But I do think that I understand it well enough to hopefully explain for questions. And then and again, just to fly through this all, my intention is to go through this, just a few comments on coronavirus. When I was a medical student, we only heard of this as a cold virus, just a really minor thing that caused cold viruses, and it's pretty ubiquitous. And it was really only described since the 60s, but once discovered, kind of investigated with our newer techniques, we find it's really ubiquitous. The coronaviruses have been around forever in humans and in animals, even things like dolphins and beluga whales and bats and civets and camels. I mean, and mice. It's all over. But it's always been a pretty mild illness, and only although there's many different coronaviruses, only 7 infect humans. But these were always fairly mild until 2002. when there was an outbreak of SARS. You may remember this vaguely. And then in 2012, another version of coronavirus called MERS or MERS. And then, of course, this recent outbreak. They all appear to start within the animal populations and then just sort of jumps over to humans. And that mechanism is really not clear. But all of these clearly had a vector that seemed to occur with bats, but go through another animal to humans. And we're not really sure how that all works. And the thing is that with this family of viruses, we're learning more about them. It's unrealistic to think that there's not going to be some other kind of version that comes up in the future, because we've seen, as we've seen with COVID-19, it does mutate and change into versions over time. And so you may have heard the term novel coronavirus. All that means is that it's a new virus strain that's never previously been identified in humans. So if you ever hear that term novel, that's what they're talking about. There's a lot of abbreviations, but I think the analogy that I could use to throw up there is HIV is a virus, but AIDS is the disease. And so so for all of these are the terms that we'll hear about: COVID-19, MERS, and SARS. They all come from different abbreviation names. So if you're confused by that, hopefully that helps out a little bit. You know, so it's really similar to all the other little viruses that do COVID. This little diagram in the bottom corner I just threw up. It's kind of a pie chart. In that pie chart, it shows that in comparison to the flu, which is second from the left, the black part of the pie shows that COVID is more fatal than flu, but not as fatal as some of the other coronaviruses. But the thing that really makes coronavirus more important than SARS or MERS is that it's very infectious in comparison. Not quite as infectious as the flu, but more infectious than the other coronaviruses. And that combination has made it really important worldwide. So as of the fall of 2019, it's really considered a pandemic. And up until just a few months ago, we have had 258 million confirmed cases, but who knows how many unconfirmed cases, and documented over 5 million deaths. That's staggering if you think about it. So far, the symptoms are largely respiratory, but there's a greater impact on the cardiac myocardium than we see with other viruses. And that is because the virus actually attacks a receptor found on the cardiac muscle. And so it's a worldwide pandemic, as we know, and worldwide things, but for this virus, it has a wider spectrum of symptoms than we see with other coronaviruses. It's a wide spectrum of severity. More organ systems are affected, and the cardiac impact is more significant than with many other viruses. For children specifically, the evidence is mixed on whether they're at greater risk to get infected or not. The trends in more recent literature seem to show that children may not be quite as at risk of getting infected as older children and older adults, but not by a whole lot. And that as children approach middle school age, their ability to get infected by the virus is similar to adults. It's also not clear if they're more infectious to others once they're infected, but most reports, again, are mixed, but most reports seem to say that their degree of infectiousness to others are similar to older children and adults. So as a group, we know that kids have milder symptoms. Most are asymptomatic. So the overwhelming majority of kids, you may not even know they're sick. About 70 to 90% probably have minimal to no symptoms or very mild non-specific symptoms. They also have much lower morbidity, meaning that if they get sick, having significant severe illness is lower, and the death rate and the mortality is also much lower than in older groups. And they recover quicker with fewer residual problems. So kind of to keep it in perspective, that children account for about, less than 18 years old, account for about 22% of our population, but only account for about 7% of reported COVID cases, about 1% of hospitalizations, and a fraction of a percentage of deaths. And this, this little diagram on the right kind of implies that. So kind of way over on the left, this is showing you that in comparison, this is in 3 countries, South Korea, China, and Italy, the rates of kind of infection and deaths in the youngest group, the 0-49, only these tiny little bumps in comparison to the death rates seen in older groups. And so children are just simply not affected as often or as severely or as profoundly as adults. But that said, there's a very small population of children who can present profoundly ill. And that's called multi-system inflammatory syndrome in children. So if you've seen this or heard about it, I just want to touch on this because it is, I think, helpful to put it in perspective in relation to the vaccine. So it's defined as this inflammatory condition from COVID-19. It affects many organ systems where they become very inflamed, including the heart, lungs, kidney, brain, skin, eyes. So multi-system, and it's an inflammatory disease. It occurs about a month after the infection, and there's different criteria, both CDC and WHO. But in general, they all have high fevers. They have high levels of severe inflammation in their bodies, and at least a couple of different organ systems are affected. And at least for MIS-C, severe illness that might require hospitalization, not from anything else, and only in those with documented previous COVID infection. So although the definitions vary, the epidemiology is kind of important. So I put up this slide because it's important for us, right? If we look at the people who are affected by this life-threatening illness, we see that it peaks in the young, that it can affect children as old, even in infancy or a year old, but the peak incidence is in 5 to 14 years old. And the median age is about 9, and that's the group that we're talking about with the vaccine, right? So its peak incidence is in children. It's pretty similar. Males get a little bit more than females. Find it more often in Hispanics and Black populations. But this graph, I think, is really interesting. This was from an article done in New York when it was first reported. And this green line is the COVID cases. And then over time, over a month, they found these little bars, these little blue bars are the pop-ups for the MIS-C, and they found that the peak of MIS-C followed the peak of COVID by about a month. And this has been repeated many times since. So COVID occurs about a month after, MIS-C occurs about a month after COVID. The pathophysiology is not really understood, but the idea, the thought is, the pattern that we're seeing is that children are affected by COVID in a normal, typical manner. Most of them don't have a lot of symptoms, if any, and they recover pretty easily and quickly. But from some sort of unknown mechanism, we find that the inflammatory system is triggered, and it kind of goes into this cascade of a very profound inflammation. And there's some host factors, some viral factors, but this inflammatory cascade leads to an immune system that sort of attacks the heart and other organs in the body. Most will have no or minimal prior symptoms of COVID. And initially, about a month after their illness, they'll get high fevers. Some GI complaints are really common to the point that it even mimics appendicitis. But then they get pretty quickly, and they can develop shock, heart failure. Heart is very commonly affected. And if there are pre-existing neurologic or respiratory or genetic conditions, it seems that those children can get profoundly ill, even to the point of it being life-threatening. There's a wide array of symptoms that individually don't seem to be that prominent, but when you put them together, fevers, GI symptoms are common, rash, red eyes, their mouths and nose seem to get really inflamed, and some respiratory symptoms are most common. See medically, though, is that they develop a myocarditis in association with this inflammatory illness about an 80%. Some of them will have shock that require medications and ICU support. They have other kind of things going on, and they may need ventilation, but not nearly as bad as the severe adults do. But they'll also have kidney inflammation and encephalopathy sometimes, and neurologic issues. So this is a multi-system inflammatory thing, and these kids are sick. About 80% of them have cardiovascular abnormalities and myocarditis and inflammation in the heart muscle is pretty common. About 60% of those with the severe disease. And many of them have a mild to about 50 to 90% have some evidence of cardiac inflammation through labs where proteins called troponins are released from the cardiac muscle into the bloodstream. BNP is a lab abnormality that kind of demonstrates congestion. So congestive heart failure things can occur in 1/2 to 90%. And if we do an echo on them, a third of them will have mild or moderate dysfunction on echo. You know, many of you may be familiar with echoes, an ultrasound of the heart. Mild to moderate abnormalities in the heart and severe abnormalities in 5%. And I can tell you the EF less than 30% is bad heart function. Although many of them have cardiac abnormality, coronary abnormalities and fluid around the heart. But keep it in perspective, even though this sounds really bad, it's actually not that common overall. In the whole United States, this is actually a slide from the CDC, and all of the tens of millions of children in the United States and all of the many millions of infections, we've only reported MIS-C in about 5,500 children with 48 deaths as of November 1st. So if we kind of think of how many children there are, this is not a common thing. Keep it in perspective. But if you're one of those 48 or you're one of those 5,500, it is very life altering, of course. So just keep it in perspective. It's rare, but it can be significant. We're also finding this phenomenon called long COVID. Long COVID seems to be that after infection, there's a small percentage of children who have these lingering symptoms of brain fog, confusion, struggling at school. They seem to not want to participate in activities that they once really enjoyed. Some of them have trouble getting to sleep or staying asleep, and others have a very profound fatigue and sleep a lot. There's big symptoms of aches and pains and breathlessness and dizziness, and it mimics a condition called POTS, which is just, if any of you are familiar with POTS, is just really frustrating for both patients and providers. So it's estimated that long COVID symptoms can occur in 10 to 15% of infected kids, even if their initial infection wasn't that bad. All their tests are negative. So if you look at their brain, you look at their heart, you do tests like MRIs and CTs and echoes and things, none of them are abnormal. And so there's no clear treatment for these symptoms that last a variable length of time, sometimes months. And of course, since this is new, sometimes years. And we're finding even adults, about 30%, I saw a recent report that 30% of adults may have long COVID. So even if it's not life-threatening, it certainly can affect the quality of life. So in overview, the risk of getting COVID is probably similar to adults, maybe not quite as easy for them to get sick as adults, but probably nearby. And then based on at least blood tests, we find that kids probably get COVID at the same rates adults do. Most kids are asymptomatic. The risk of infectiousness is similar. But any sickness is undesirable and disruptive, and some can get profoundly sick, as we talked about with MIS-C. And then of 8,300 hospitalizations as of October of this past October, 1/3 required ICU. MIS-C is life-threatening, and of those 8,300, something like 20% had myocarditis. Again, deaths can occur. And what this table is showing, that in the kids 5 to 11, 5 to 11, 2% of all deaths in that age group are from COVID. And so the really important thing is that although this isn't many, it's important for those families, of course. It's not a big proportion of the overall deaths, but it is preventable. And that's the really sad thing about this, is that although it's not a big impact, it's reasonably preventable. And another thing, just to kind of keep it in perspective of other illnesses that we vaccinate for varicella, for rubella, and rotavirus. And what this bottom line is showing you, or this thing all the way on the right, so look at COVID-19, the average deaths per year from COVID stripped everything else that we kind of take for granted, that we've been vaccinating for a long time. That the rate of death prior to vaccination for COVID is higher than all the other things that we vaccinate for. And so, as again, an overview, even though children may recover, and some will have long lingering symptoms are possible. And as mentioned by Autumn, there is a risk of transmission to others at home or at school. And although the kids may not have a lot of disease, some of those adults might have really significant risk for life-threatening COVID. So it's not completely benign. Autumn also touched on this. So this is kind of a busy looking picture, but what I want you to focus on is right here, this dark blue line. That dark blue line represents the 5 to 11 year age group. It started off at 5 to 11 years, had a very tiny proportion of overall infections. Tan and brown and orange lines are older age groups. And it kind of, as we've had these peaks occurring over time, we're seeing more and more of the Delta variant in here, and you see it kind of bump up now, the 5 to 11-year-old group. And now if we see in this part, in this most recent kind of handful of months, the 5 to 11-year-old and the 12 to 17-year-olds are the two highest proportion lines of all these age groups. So that although previously kids have escaped getting a lot of disease, now we're finding over time that kids are getting a greater proportion of infections than they used to, meaning there may be greater risk to them. A greater proportion might be getting that MIS-C or other illnesses. And of course, there are ripple effects. We're seeing schools getting closed and teachers being affected, and with that, we're getting school closures, and that worsens educational opportunities. And we know really well that kids are not learning as well virtually as they are in person. And it's hard on families to try to teach their kids, and it's hard on the kids to learn. They're missing social opportunities. So COVID has this ripple effect in worsening mental or emotional health and their social development. There's a loss of caregivers taking care of them. There's impact of families and parents trying to care for those health problems. And then there's a risk to other family members, the grandma and grandpa, their aunts and uncles who are obese and have heart failure and respiratory issues, and they might have otherwise escaped getting seriously ill if the kids didn't bring it home to them. So what can we do? It's common sense, and we've said this for many years. Certainly, if there are high risk exposures, we probably really need to avoid those if we can. But what that means is we're avoiding the things we enjoy. We're avoiding going to the Friday basketball game, the high school basketball game, or going to meetings and concerts and gatherings, but they are high risk, and trying to cut those out if we can is important. And certainly if you're sick, don't go out because you're exposing others. Social distancing when possible, masking clearly reduces the risk. It is not perfect. And I think that people are really good at picking up abnormal messages or holes in the message. The message should be that it's not perfect, but we do know that if you are masked and you go into a room of infected people, you're not going to get as sick from those infected people in the room if you are masked. And if you are sick, it definitely reduces the chance of exposing others. So it might not be perfect, but it certainly absolutely reduces risk. And it's hard to do that for ourselves and our kids, but it's important. Of course, hand washing when contacting others is important. Vaccination is what we're all talking about with, and vaccination can be a powerful tool in the toolbox to address the risk of COVID. As talked by Autumn, studies show that within this age group, it is 91% effective. And by that, what they're defining that is comparing the kids who get placebo, meaning a fake vaccine, comparing those to the kids who did get the vaccine, and using the statistics, statistically showing this is 91% effective. To put that in perspective, the flu vaccine is about 70 or 80% effective. Some of the other vaccines we take for granted, the tetanus, the MMR, they're about 80 to 85% effective. So a vaccine efficacy of 91% is really very good. We also know it's safe. In this 3.5 months or so of study, there were no serious adverse events related to the vaccine. It's kind of funny. They reported a kid who broke his arm. They reported one kid who had a septic arthritis that was unrelated, but they still reported within this group, but there were no adverse effects from the vaccine. There were no deaths. There were no hospitalizations. And most importantly, as I wrote in purple on the bottom, there were no vaccine-associated myocarditis in this group. About 3% had local reactions that were considered mild, things like swelling, soreness, redness, which is really common with almost any vaccine. And the rate of 3% for local mild reactions is really not that much different from any vaccine. But I wanted to special touch on this vaccine-associated myocarditis because a lot of people have used this as a concern for not getting their vaccine, right? Because this is myocarditis, kind of conjures images of kids with bad function, really sick illness. For instance, the myocarditis in MIS-C is really severe and is really life-threatening, and myocarditis from other causes, even prior to COVID, can be really severe. So this has created a lot of concern, this vaccine-associated myocarditis. It was first described kind of late in the summer. Reports emerged about myocarditis occurring in adolescents and young adults getting the COVID vaccine. It seemed to be really most common in those 12 to 29. There really is a significant male preponderance, and most often 2 to 3 days after their second vaccine. They would present with some chest discomfort and some breathing difficulties, not profound, but enough to come in, get seen. When they came into the hospital to get checked out, what they found was almost all of them had some elevations in their cardiac enzymes. This protein that's a part of their cardiac sarcomere, the myocardium. When the heart muscle is damaged or inflamed, it releases these cardiac enzymes, the troponins, into the bloodstream. And all of these patients had really significant elevations in those enzymes, and many had EKG abnormalities. And if MRI was performed, almost all of them had abnormal markers associated with myocarditis. But here's the really important thing. Although there are lab markers of myocarditis, EKG markers of myocarditis, and MRI markers for myocarditis, they didn't have very many cardiac abnormalities on ultrasound. The function was still normal. The valves are not leaking. The valves are working great. The function was normal in most. There might be a little bit of fluid around the heart, but not a lot. So although there are these markers that identify these kids as having myocarditis, that when you kind of look at them pragmatically, they just didn't have a lot of abnormalities by echo. With this vaccine-associated myocarditis, they were treated variably. At first, of course, there was this nervousness, this knee-jerk that they had myocarditis. They got admitted. They're kind of watched. We treated them the same way that we do all kids with myocarditis. So the initial ones often got steroids and IVIG and some of the treatments that we give for myocarditis. But over time, we kind of realized that their function was really quite normal. And so over time, most of them now are just being treated with Motrin. That almost all of them have resolution of their lab abnormalities within days. Their hospitalization is uniformly really brief, maybe 2 or 3 or 4 days. And if they were in the ICU, a lot of times it was this precautionary knee-jerk thing because of a myocarditis rather than them being really sick. Although the EKG changes seem to persist in some, and of course it's really early in the game, we don't really know what that means long term. The take-home message is that although these kids are admitted with myocarditis, they're really recovering uniformly with mild treatment, with minimal symptoms, with minimal lab problems, most of which recover within days. If they had echo changes, those are resolving. I think the real kicker is this line on the bottom. The incidence of vaccine-associated myocarditis is about 1/10 of the incidence of MIS-C in the same age group. So this is saying that if you get the vaccine, yes, you might get a myocarditis, but it's really mild. You recover from it really easily. But if you don't get the vaccine, you have a 10 times greater risk of getting myocarditis from the virus. And that's just the MIS-C. That's not counting the myocarditis from others. So when you kind of balance out, what we're showing here on the left is if we project the numbers thus far, the incidence of myocarditis associated with the vaccine, that is this batch on the left. We would see in different age groups, 12 to 17, 18 to 24, and 24 to 29, based on the incidence that we know of vaccine-associated myocarditis, you'll see that about this many cases, in the United States. The numbers are not big. Of all the millions of kids, again, we're talking about something that's really pretty rare, maybe the equivalent of dying in a car accident, the equivalent of getting struck by lightning. So really low, maybe that's an exaggeration on my part, but a really, really low interest. But compare that in the same interval to the same intergroups of those who are not getting vaccination. We're talking about here maybe handfuls of dozens of people getting vaccine-associated myocarditis. But what we're going to see is thousands of COVID cases, hundreds of hospitalizations, dozens of ICU admissions, and death. You'll notice that I don't have those on the left, they are on the right. And so even though there is a vaccine-associated myocarditis, it's not as common, it's not as bad, and therefore not a reason to justify avoiding the vaccine. If anything, knowing the incidence of myocarditis without the vaccine and knowing the incidence of myocarditis from the vaccine, the evidence is overwhelmingly in support of still taking it despite that slight risk. This is just another kind of thing showing the same thing. If we're talking about how many hospitalizations and COVID things are on the left, on the right is the case of myocarditis from the vaccine. And there's a marked reduction in hospitalizations and illness if you've had the vaccine compared to those who don't. So in summary, I'm getting to the end here, and I'm sorry this took a while. So in summary, children with COVID-19 clearly do not get as sick or as often as adults. And as a group, they are less severely sick. There's fewer complications, there's fewer hospitalizations, and there's fewer deaths. Absolutely, it's undeniable. And they probably get the virus probably about as easily. And they probably they spread the virus probably about as easily. So what does that mean? That means that even though they themselves are not getting sick, they're not really showing a lot of symptoms, they're still getting it and they're still transmitting it. And so that means that these asymptomatic kids probably serve as a reservoir for ongoing potential infection for others. Even though they're not severely sick, there's still some who can be severely ill. Some are hospitalized with COVID, especially if they have other medical conditions. It seems that developmental and neurologic problems seem to predispose them to some degree. Trachs, those having chronic respiratory symptoms seem to be at greater risk. Some cardiac problems, greater risk than the general population, but not as greater risk as those with neurodevelopmental problems. And in that group of kids who get hospitalized with COVID, not with MIS-C, 12 to 20% of them have evidence of cardiac abnormalities. This is not the MIS-C group. This is just those who are getting hospitalized with maybe moderate level disease, right? In addition, there's this risk for MISC. MISC has a spectrum of severity, but a severe fulminant, meaning unrelenting course, is possible. The risk of death is low, but it's not zero. But if you that risk of death is low in the hands, in the care of special pediatric medical resources, pediatric ICUs that are not present in northern Michigan. So the best survival is in those with those resources. So if your child were to get MISC, they would not get the best care up here. We don't have the resource to do that. We would probably have to put them in the hands of ICUs that deal with this sort of thing downstate. So if they get this acute illness and they get in the hands of those people that care, the good news is most will recover. But again, there's a certain segment of those kids who have MISC who have a long-term disability, a long-term cardiac dysfunction after MISC. Myocarditis has also been reported in 1 to 3% of athletes, even in those who don't have symptoms. Maybe that's been overplayed. We've been doing MRIs at U of M and all the Big Ten athletes, and we're finding that that although we're finding MRI evidence of myocarditis, if you're not having a lot of symptoms or dysfunction or problems, they all seem to not have any long-term stuff. But the myocarditis is out there, even in those who get COVID, but not symptoms. So myocarditis is again in that general population of those getting infected. And then as we talked about, long COVID can occur maybe in 10 to 15% of kids infected with symptoms that linger for variable lengths of time, months to years, adversely affecting their quality of life with no specific treatment available for that. So that's some of the things that kids will get from their COVID infection, right? COVID has an impact beyond their infection, risk of infection to others who themselves carry a greater risk for symptoms or adverse outcomes, missed work for parents and families, and other family impacts from illness from their kids, school closures with negative impact on learning and social development, missed social and recreational opportunities, goes on, right? And although there are reports of vaccine-associated myocarditis, so far it's turning out to be a pretty mild illness with hospitalizations that are short. Most need only Motrin or so for treatment. Although they have really definite abnormalities in lab, MRI, and EKG, most of those resolve over time. And the overwhelming majority have no overt functional abnormalities by echo. And when they do, those abnormalities resolve within days. Autumn kind of touched on this. The vaccine is now available for children down to age 5 years old. That it appears to be effective, 91% in terms of perfecting symptomatic COVID disease, and with no hospitalizations or adverse outcomes reported thus far. That protector titers are high and it appears to be safe. Again, with no vaccine-associated myocarditis thus far, no hospitalizations, no deaths, and no serious adverse events in the 5 to 11-year age group. So it has a very favorable risk and benefit ratio. To the point that when we talk about the benefits, the prevention of COVID disease and all the things and all the myocarditis that occurs, that although not common, certainly much more common than the vaccine-associated myocarditis. It would prevent the most severe aspects of COVID disease, such as hospitalizations, MISC, and deaths. That it helps prevent the transmission to others. And it gives you greater confidence that we can safely return them to school and their social interaction. And the risks of the vaccine are there. I don't think we can not acknowledge them, but the myocarditis and rare events after vaccine is 1/10 the rate it is in the COVID infection. And if they get infected with COVID, the risks of bad outcome are far greater and 10 times greater at least than those who have been vaccinated. So again, just a quick reminder, as a cardiologist, I do not consider myself an expert in any of this stuff, but all this stuff is in the literature. If you wish citations for them, I can provide them. And this is the end. I love throwing this up for all my lectures. This was when I was in the Navy in the Persian Gulf, and you'll notice the sun is setting, not on a horizon, but behind a wall of steam because it was just that hot. You couldn't see the horizon most often when we were in the Persian Gulf. This is the Indian Ocean. This was off the coast of Hawaii, and this was in San Diego. Sunsets from all over the world. So that's the end of my little talk. I wanted to pop this up here again. Just a reminder who I am. I do live in northern Michigan. I have outreach clinics in Traverse City, Petoskey, and Alpena. And that's my contact information if you need. And there, and that will be available, I guess it's a recorded, you can kind of access to that. And after this, then Missy will have my contact information as well. And my phone number and of course, email and being able to get in touch with me at any other time. I think that's about it. I'm going to minimize this and I guess find out if anybody has any questions. I'm sorry if that took a long time.
All right, well, bring us back together. And I'm so appreciative of both Autumn and Dr. Maurer. Thank you so much for being here today. And this is, you know, what most of you have been waiting for, is this just chance to ask experts in our backyard who know kids, they know pediatric medicine, they've known this vaccination process and some of the pieces that go along with it. And I wanted to give you guys the chance to unmute yourself and ask questions. And we have about 15 to 20 minutes, and we will forego the, we'll just delay our other agenda items are perfectly fine to put
I'm
off.
so sorry, it took a long time.
No, you're it's totally good. It's so rare that we get a nice window here, and that the benefit of this recording can go to
touching on the bits and pieces. There's hours of talks out there. I mean, I'm only touching on the bits and pieces, and I may have gone a little bit more in depth than I needed to, a little bit more you needed, but I still want to get what was important, and I apologize, but I'm still only glossing over things. So
thank you. Okay, so questions, guys.
I just wish we got continuing education for Dr. Maurer's time and talk to us.
That's right. Wow. There's a benefit.
Yeah.
I want to draw on your point about the resources available to parents whose children get sick. We have had a death here in northern Michigan from COVID. Mm-hmm. It's not, you're not immune to this. And I've experienced it as a parent when you don't have the medical services close to home that your child requires.
Right.
So what symptoms would drive a child to be transferred to another hospital?
So, so I actually did a couple of education sessions for Munson Hospital, you know, kind of grand rounds, sort of things talking about it. But what we find is the kids who are presenting with the really severe ones have about a month after their illness, really high fevers. They have a lot of GI symptoms. It mimics appendicitis. They're really nauseous, they're throwing up, they have a lot of discomfort. And then when they show up, you know, quite often they have a really fast heart rate, really fast respiratory rate, and the providers in the ER have been asked to clue in, especially if the kids have evidence or history of exposure a month or so before, to look for the inflammation and things. And if they find inflammation and evidence of these kind of, although they're vague symptoms, kind of the pattern sort of stimulate them to look further. And if they find evidence, they know these kids can go south, and they'll often send them away probably earlier than later. Again, it's not really common, but if you're the one, it's there, and it's hard to pick the needle out of the haystack. But the things you're going to see most often are really high fevers in conjunction with significant abdominal symptoms and maybe a fast heart rate and a fast breathing rate.
Thank you. And typically, parents don't travel with children when they have to be transported. So
they may not, yeah.
Yeah, and so that's kind of hard for a lot of people to relate to.
But there's not a lot of room in the ambulance, and there's not a lot of room, especially in a helicopter, and that is hard. You want to be mama bear and baby bear, but you're not going to be able to protect them in comparison to their medical needs, and so you may actually be in the way and hinder the care, and it's hard to separate from your kids while they're being transported, but otherwise they can't do their work. It would be really hard.
All right, Bailey, Dana, Megan, Clara, any questions you have?
I have so many questions, but I'll try to hold it back. So Unfortunately, I couldn't protect my children well enough until the vaccine came out. So they got COVID like a month and a half ago. And I've noticed my younger one, he keeps getting like really, really pronounced red eyes. Is there anything I can do to help him not have MISC? I mean, I've read about like antioxidants are supposed to be helpful, but whenever you Google it, it says don't get COVID, and it's a little too late for that on my end.
Yeah, exactly. You know, we've not found anything. We're not certain how kids get MISC, right? We know that it's related to their immune system, and that there seem to be some. We've not been able to identify any markers that identify who's at risk. It seemed to be some features of that virus with that person's immune system, and we don't know what those markers are, and it just seems to trigger this cascade. And so, because we haven't identified those things, we don't know what to target and what to treat. We do know that if you are going to have MIC, you almost always have it within a month or so of your COVID illness. So if you're outside of that month, your risk of having MISC is negligible. But unfortunately, there's no vitamin or dietary thing or exercise that we know of that would reduce your risk of getting it. You know, it's just sort of like, you know, kind of getting struck by lightning and kind of, you know, have this axe hanging over you, kind of waiting. But if you get outside that window of time, then your kids are no longer at risk. And I don't think I've ever heard of anything otherwise to prevent or lower that risk. Because if there were, then we'd all be talking about it. There may be case reports where somebody, you know, my Aunt Clara's second best friend's cousins did vitamin E oil and they didn't get it. But I don't think there's any scientific evidence to prove beyond case reports or personal experience that would prove that anything is of benefit in preventing it.
Okay. And if my older kid has had some symptoms of long COVID, you know, he still is pretty exhausted and having trouble. So when I vaccinate him, is that of a concern because he's still suffering from symptoms, or no?
No, there's no evidence the vaccine worsens symptoms or worsens their condition, and there is also that's something I didn't put in. There is also the recommendations are even if you've had COVID, that you should still get the vaccine. They don't have increased symptoms or side effects in comparison to those who have not had COVID. But the feeling is that it sort of boosts your immunity and provides a wider net of immunogenic protection against variants that may still come. You know, I don't mean to be painting crepe, but this isn't going to go away. This is with us forever now. And I don't think Delta is the last variant. Delta is a significant variant. And there's going to be some that are not as bad as Delta, but there may be some that are worse. And so I kind of feel that we should be doing everything in our power, even though kids have had it, to still get the vaccine, because we have shown it does seem to provide better immunity than native infection and preventing against symptoms from Delta. So I would still say, I still think they would, and I don't think it's going to worsen. We've not shown any evidence that it would worsen their long COVID symptoms.
Okay. And one final question. I had breakthrough COVID at the same time. I should still get my booster though, correct?
I think so, yes.
Okay.
Yeah, and so again, I think that that's a bad marketing thing, and people are grasping onto these straws and saying, oh, look, you had breakthrough infection, you shouldn't get it because it's not perfect. Well, no vaccine's perfect. We know that you get flu after having had the flu vaccine. We know you can get pertussis after having the pertussis vaccine. We know that all of the immunity for all of these vaccines wanes over time, which is why we have tetanus boosters and pertussis boosters and all these sort of things. It's unrealistic to think that we're not going to get 100% protection, but we know that those who are vaccinated are not getting hospitalized and are not dying and are not getting severe illness. So it's unfortunate that I'm sorry you got that after the vaccine, but I would still encourage you to finish your course as well.
Is there a certain length of time you should wait, either for my kids after having infection or me after having breakthrough, at which I should get a booster or at which they should get vaccinated, or does it not matter as long as they're not currently ill?
Autumn may know the answer better than I, but I think it's 3 or 4 weeks.
So there's actually, as long as they're not currently contagious, so no longer in isolation or quarantine after an exposure or an infection, and as long as their symptoms are improved, then they can be vaccinated. And
What she said.
so no, there is no standard wait time afterwards to boost immunity or anything like that. We presume that you wouldn't encounter another infection within 90 days, but we don't know that for sure. If it were my child, I would just get them vaccinated now.
Okay. And do you know if MISC is something that can only happen after a first time infection with it? Because as we know, people can get infected with COVID more than once. Is it only for kids after the first time, or is it possible that they could get COVID again in a year and get MISC from it?
I don't think I've heard anything specifically about getting MISC after repeat infections or getting COVID after vaccination. I think that all the stuff I've seen reported, again, not an expert, but all the stuff I've seen seems to be after primary infection.
Okay.
Yeah. Good questions.
I Google a lot, and Dr. Google is not as good as an actual doctor. So thank you.
Good and bad with that,
doctor.
right? Good and bad with that.
I have a couple of questions. In February, which was a long time ago, it seems, but not really, my oldest was potentially exposed and presented all the symptoms. He had 2 negative tests, both. He had 2 different kinds of swabs, one a nasal swab, one a saliva swab, and it came back negative for both cases. Now I've been trying to figure out what's going on with him other than he's just a teenager, but I'm wondering if he actually did have COVID, had all the symptoms. He had no sense of smell, no sense of taste, a fever, vomiting, all the symptoms were there. And he has been vaccinated. He was vaccinated in June, but because he's 16. But I'm wondering, like, is there data out there that says that kids that may have had it but weren't officially counted could have long-term COVID? I don't know. I'm wondering.
Yeah, so it's hard, right? Because we don't have a test. As I've told you, all the testing that we do in those who, have clear infection and we're talking about long COVID, they're negative. And and they mimic other things like POTS. They mimic other non-specific medical conditions that can plague kids who haven't had COVID. And in my experience as a general pediatrician before I was a cardiologist and my own kids, I had kids who just won't get out of bed. You know what I mean? And so it's really hard to say what's normal in normal teens, what is abnormal teens that don't have COVID, like POTS and things like that, and what is long COVID. I don't think we have any way to distinguish among them. We do know that in terms of the testing that you can get false negative tests, but less so if you've had not the swabs, but the other one. If you've had a negative one, that's more likely to be negative. And if he's had 2 tests that were negative, less likely that he had COVID. So that although there are false negatives, the chance of them being rare is being COVID false negative twice as low. So
I'm just thinking, and I'm at the point now where with our younger ones, I'm convincing my husband that it is time that we get them scheduled for their COVID vaccinations. We do have a 4-year-old, so we're like, well, she can't get it yet. And is there any talk on the horizon? Have you heard anything, Autumn, about when they are going to expand it further down the line?
I haven't seen anything like super recently, but I know they were talking about in the new year to look at 2 to 5-year-olds. So I think we're probably at least a couple months away from that.
She'll be 5 in April, so.
So you're not too far off anyway.
Yeah, she'll get vaccinated before she goes to kindergarten, but she's in preschool right now, so it's kind of like, okay. But we're still in the process of, okay, I've had to debunk a lot of myths that he has heard, and said, why don't you look that up again and see exactly what that person said? And then he'll listen to the podcast again and he'll be like, oh, okay. So, and I had a
Mhm.
conversation with our pediatrician about it as well. So we're working on it. It's just a matter of getting.
It's so hard. Socially, we see a lot of kids are extra anxious about this vaccine, and I think they are. They're getting that messaging in school from their peers or from peers' parents or even from teachers. You know, there's a lot of fear and anxiety out there. We had 3 kids vomit during COVID clinics, their pediatric COVID clinics, and I think it was just those nerves. You know, they didn't have any other symptoms of any kind of reaction to the vaccine. It was just, they were so anxious.
And kids present that no matter what. It's
Yeah.
so it doesn't matter if they're really sick or not. A lot of times they just present with a upset
They
stomach.
carry the weight of the world, don't they? They really, yeah.
And unfortunately, the social media has grasped onto these straws and then kind of set up little boogeymen and you know, and manipulated and I can't go on how much that the social media has undermined and politically has undermined our ability to reach out to people. But medically speaking, and based on the medical data, no, we're not injecting little nanobots to try to control your mind. You know, the United States is not trying to control the human population with these vaccines or whatever is out there. You know, again, you look at the medical data, you know, that, you know, but I think the messaging is important too from the other side. I think that it's not perfect. It is not 100% effective. It is not going to prevent all infections, but it is going to provide a greater margin of safety than not being vaccinated, definitely.
So we're
And herd immunity is real, right? The more of us that get the vaccine, the more effective it becomes.
But you can't rely on your herd immunity, and you need to get there. And you don't get
Yeah.
herd immunity until about 2/3 of the population is immune, and we're not there yet.
Mm-mm.
Well, we're going to get there most likely with the efforts of health professionals like you guys that help everyone understand and dismantle disinformation and get the facts about what is really out there and what risks and benefits of this vaccination are. So we really appreciate your time, and it's so nice to know we have health professionals that are not only our parent coalition can lean on, but our broader audience of parents across our 5 counties and beyond. And we do have pediatric subspecialties in our backyard and people that we can call on. So thank you both, and we'll look forward to sharing this recording out, and happy Thanksgiving to everybody.
Yeah. Nice to meet you all. Thank you.
Nice to meet
Thank you all for attending.
Thank you.
Good to see you, Clara.
Good to see you too, Adam. I want to make sure I said hi.
Mm-hmm.
Okay.